Every 30 seconds, somewhere in the world, a baby is born with a life-threatening but highly treatable congenital heart defect. Congenital heart defects, CHDs, are the most common types of birth defects in newborn babies, with over 1.3 million babies born each year around the world. In Africa, chances are that these children may not live to see their third birthdays. Even if they manage to, they will never reach their full potentials if they remain untreated. In Nigeria, an estimated 85,000 children are born each year with CHD. Sadly, less than 200 open heart surgeries are performed yearly on these children. The number is too low, and there are several reasons for this, chief of which is that most parents live below 1,000 naira a day in Nigeria. This is worrisome, but Hospitals for Humanity, HFH, is helping to salvage the situation.
We began Hospitals for Humanities maybe when I was in medical school. We're based out of the U.S. We're a 501c3. It started probably when I was like 19 or 20. I came back home to Nigeria, and I was hospitalized. And it was because I had I wanted to be like everybody else and drink the local water out the faucet. And the next thing I know, I was vomiting, diarrhea, and it was whatever. And then they took me to the hospital at supposedly one of the best hospitals in Lagos. And I was unpleasantly surprised at the quote-unquote better hospitals that we had in Nigeria. So it was at that moment that I decided that this was not going to be the story of Nigeria in healthcare. We have a better story to tell. It takes a lot of planning. It takes the concept is one thing, but then you put that concept on paper, and then implementation becomes another thing, especially in an environment like Nigeria.
As an international non-profit healthcare organization, HFH is committed to providing free surgical procedures to children born with heart disease. This is a huge relief, especially for parents who can't afford the cost of treatment. Meanwhile, HFH has specifically worked in Nigeria on various healthcare system initiatives. It has screened over 1,500 children for congenital heart defects, performed pediatric cardiothoracic surgeries and cardiac catheterizations in Nigeria on 100 patients with a 96% success rate that is comparable to any first-class institution in the world. While providing free open heart surgery is important to HFH, supporting Nigerian healthcare professionals and hospitals with capacity building within the pediatric cardiac space is also a mission. We have been successful in carrying out capacity building of the local medical staff through knowledge and skill transfer from our US-based team of experts. Our goals include creating a nationwide systemic screening program that detects CHD in all infants within 24 hours of birth in Nigeria using the simple pulse oximetry test, and conducting 500 free pediatric open heart surgeries annually for African children.
The only reason why this is even sustainable in the way that it is now is because I recognize that this is way beyond me, and this is way beyond the people of Nigeria. It is so much bigger than that. I think it's a movement, it's a change, and you really have to be able to understand that concept before you do anything. Practically, we're looking at you have to fundraise.
Today, we have an evolving list of over 1,000 children in our database who have CHDs and need open heart surgery immediately. This list is revolving because children will die waiting for open heart surgery. You can make a one-time donation, a recurring donation, or become our corporate partner by visiting our website at www.hospitalsforhumanity.org. Join us on our mission to save children in Africa, one free heart surgery at a time.
is suffering from congenital heart defects and the surgery or surgical intervention that that child requires. Like I said, we've worked in Nigeria over the last 10 years, and we are passionate about ensuring that children do not die because they cannot afford heart surgeries. So that in a nutshell speaks about what we do. With what we do, we raise a lot of awareness, which brings us to the reason why we are here for this webinar. We raise a lot of awareness for this cause, and we ensure that people get to know the reason why, maybe a child is developing certain symptoms, or a child is sick or having certain symptoms. If they notice it, they can always check with their doctors and, ask for some further investigations to be done on that child. So today we will have a lot of our physicians, a lot of our doctors, technical doctors, surgeons, cardiothoracic surgeons, and all of that in the room today, just teaching us and helping us to understand what this is about and how parents, guardians, and people around can detect this and what they should do when someone is going through or having this occasion of any form of symptoms that really indicates that there is a heart failure or a heart defect going on. So very quickly, I'll just get out of the road and allow our very first speaker to come up. Are we ready? Can we take our first speaker, please? So our first speaker is Professor Olukemi Ige. She's a professor, a pediatric cardiologist in the University of Jos Teaching Hospital, and she's worked in this field for so many years. Her profile is on the screen, and she will be talking to us today about the effects or the way we can detect congenital heart defects easily in children. Please, let's take her now. Thank you.
Good day, everyone. Happy Congenital Heart Defects Day and a happy Valentine's Day to you all. I'm Olukemi Ige, a consultant pediatric cardiologist at the Jos University Teaching Hospital and a professor of pediatric cardiology at the University of Jos in Plateau State in Nigeria. I'll be talking to you for the next 15 minutes on congenital heart defects in Nigeria. I would like to share my slide now. My topic will be on the current realities of congenital heart defects in Nigeria. And I would follow this particular outline here. So by way of definition, we'll define congenital as any condition that exists from birth. And a defect is a lack of something that is necessary for completeness according to the Collins Dictionary. So a defect is a structural problem. We can therefore define congenital heart defect as any condition that results from an abnormal development of the heart, and it's a structural abnormality. We'll look at the types of congenital heart defects, but to do this, we must understand what the normal heart looks like. And a normal heart is basically made up of 4 chambers, 2 on the right and 2 on the left. The right and the left-sided chambers are separated by a septum, which is usually intact or should be intact. On both sides, there's a smaller chamber called the atrium and a larger chamber called the ventricles. These are connected by a valve, which acts almost like a door and allows blood to pass from one chamber to the other, or stops blood from passing, depending on the phase of the cardiac cycle that the heart is in at a point in time. There are also valves that allow blood to pass from the ventricles into what we call the great vessels. So from the right ventricle, blood passes through a valve into a great vessel that goes to the lungs and causes oxygenation of the blood there. And from the left side, it passes through a different valve that sends blood to the rest of the body. This is important in understanding the types of congenital heart defects, since we said it's an abnormality in the development of the heart. So look at a few types of congenital heart defects here. We talked about the septum that should be intact. When there is a defect in the septum, either at the ventricular level, called the ventricular septal defect, or at the atrial level, called an atrial septal defect, it results in a type of congenital heart defect. We could also have abnormalities with the valves. In this case, we have an abnormality with the valve that allows blood to pass from the left ventricle into the great artery that takes blood to the rest of the body. And this valve is smaller than it should be, so it's called a stenotic valve. Also, this great vessel that takes blood to the rest of the body has a constriction at this point because of some problems with development, and this is called a coarctation. Other types of congenital heart defects could include a total absence of a valve. In this case, the valve between the right atrium and the right ventricle is absent, and this led to the underdevelopment of the right ventricle. So we have seen from these that congenital heart defects can vary and may be simple, or they may be more complex. Most of the lesions I've shown you, even though they occur in a picture, can also be single. Sometimes we do have multiple lesions occurring at the same time. In this case, we have a ventricular septal defect, which we have talked about before, and the valve that leads out of the left ventricle is now getting blood from both the left and the right ventricle. So the valve here is said to be overriding this ventricular septal defect. So we also can see from this picture that congenital heart defects may be simple or more complex. To better look at the current realities, we must first take a trip down memory lane to look at the history of congenital heart defects in Nigeria. Congenital heart defects in Nigeria was first studied by 2 doctors, Antia and Gupta, in the 1960s. This was, however, before the echocardiographic era. What I mean by this is that to make a confirmatory diagnosis of congenital heart defects, we need to do an ultrasound of the heart, which is called echocardiography. So in the pre-cardiographic era, the first study that was ever performed in Nigeria showed that the incidence, which is the number of new cases of congenital heart defects, occurred in 3 to 4 babies in every 1,000 births. And these births were both live births and stillbirths. So the diagnosis in this case was made from clinical examination and also from autopsy. Studies after this, before the pre-echocardiographic era, were based basically on clinical findings and autopsies, and not many studies were performed even after echocardiography was introduced, because as a nation, we battled more common diseases in children such as malaria, diarrhea, and other infections. Studies that were performed on congenital heart defects from the 1990s were mainly hospital-based studies and included small sample sizes. So we really couldn't determine from these studies what the actual occurrence of congenital heart defects were. What we knew at that point in time was most of the defects were simple, and it didn't really look as if this was a major problem in Nigeria. Most of the studies estimated congenital heart defects in Nigeria and other African countries to occur in about 2 babies for every 1,000 live births. And this looked not very important compared to estimates that were obtained globally, which placed the occurrence at 8 to 10 babies per 1,000 live births developing congenital heart defects. Let's look at the current realities. In 2021, however, we had 2 studies from Nigeria that looked at the birth prevalence of congenital heart defects, a study in Jos and another in Benin City. And we found congenital heart defects in 14 and up to 25 babies for every 1,000 live births. The good thing with this is that even though the figures seem large compared to the global studies, most of the lesions found were mild lesions. However, babies with moderate to severe congenital heart defects were about 12 in every 1,000 babies. And we can say that this is comparable to global studies that placed the average birth prevalence at 8 to 10 babies per 1,000 live births. Most of the babies that have moderate to severe congenital heart defects would require heart surgery or cardiac surgery. But like we would see very soon, very few of these have access to this before they succumb to the illness. Looking at the clinical presentation of congenital heart defects in Nigeria, the presentation could vary depending on the type of congenital heart defect and also the severity of the defect. Babies can present with several things: fluid discoloration of the lips. Some would have poor feeding, breathing difficulty. Some may come in shock. Others don't have any symptoms at all. The table here on the right shows symptoms that occur in older children. There may be some medical jargon here, but it's good to note that these symptoms can also vary very widely. Some would have chest pain. Some would have recurrent chest infections, swelling of the limbs, respiratory difficulty that may prevent them from sleeping properly at night. Some would have problems with their milestones and may not achieve their milestones as they should. And for others, it may just be a problem with failing to thrive, and they do not grow as well as their other peers. The diagnosis and treatment of congenital heart defects in Nigeria is still a problem. We know that diagnosis became better with the availability of echocardiographic services in the 90s, but we do know that these services are not widely distributed. The table here shows the different geopolitical zones in Nigeria. We have a total of 45 echocardiographic machines in the country. This is as at 2017, most of these echocardiographic facilities were in the southwest and in the north central parts of Nigeria, with very few in other geopolitical zones. Other diagnostic services are not readily available. They're also expensive, especially in a country where healthcare is mainly out-of-pocket expenditure. There are also lack of facilities for the treatment of congenital heart defects in Nigeria, as most of these would require cardiac surgery. Also, there is a scarcity of skilled manpower for the diagnosis of congenital heart defects. Physicians with echo capabilities in 48 centers, there were only 26 physicians with echocardiographic capabilities out of 48 centers that see patients with cardiac conditions. And it's also worthy to know that it also affects treatment, which I've mentioned earlier, is basically cardiac surgery. And as few as 21 adult surgeons and 10 pediatric surgeons in the whole country available. These numbers may have gone up slightly, but we still have a lot to do in this area. As a result of this, therefore, very few children with congenital heart defects have access to treatment before they succumb to their illness. Other challenges that affect prompt and adequate diagnosis and treatment of patients with congenital heart defects in Nigeria include poor health-seeking behavior. We know that parents would visit roadside chemists and pharmacies and only present in the hospital when they think that they have no other option. I've mentioned out-of-pocket expenditure as a challenge. Also, resources for management are overshadowed by commoner conditions, especially infectious diseases, which still plagues a lot of Nigerians. The healthcare system is also not well funded and badly managed. Parents who can afford to or who have the availability of funding seek treatment in other countries listed here. And because of this, Nigeria has lost a lot of money to medical tourism. As a result of these challenges, cardiac missions were birthed. Cardiac missions basically involves patient care, both medical and surgical. Here it's mainly supported by an international team. Most of these missions are carried out regularly, usually once in a year. Sometimes it could be once in 2 years, or sometimes biannually. Most of these cardiac missions also ensure transfer of skills from the international team to the local teams. The first recorded cardiac mission in Nigeria for children with congenital heart defects was in 2003. This was halted because of some challenges, but resumed again in 2013 because some Nigerians in diaspora wanted to bridge this gap that was noticed in treatment of children and adults with congenital heart defects. The good thing is that presently in Nigeria, 2 facilities have transitioned from cardiac missions to surgery that is autonomous by the local team. These facilities are in the southwestern part of Nigeria, and this therefore limits access to children with congenital heart defects in other geopolitical zones in the country. These 2 facilities in the southwest too will not be enough to take care of the number of children and adults presently living with this condition. So the challenge presently still remains that we are still unable to care for children with the most severe forms of congenital heart defects. Most of them would die within the first week of life. There are also still more patients who are not able to access prompt cardiac care compared to those who can. and there is need for more holistic training of Nigerian healthcare workers in this area. There's also a dearth of surgical facilities needed for the treatment of these patients. So in conclusion, while we do know that congenital heart defect is as common in Nigeria compared to other parts of the world, we know that challenges still exist. There have been strides made towards caring for children and adults with this condition in Nigeria, but we can do more. I think outside the box to provide health for all Nigerians for the sustainable development goals, including good health and well-being.
Fantastic. Thank you, Professor Kemi Ige. That was a wonderful presentation on the current realities of congenital heart defects. So next up, we are going to be hearing from Dr. Wale Olabi. He'll display his bio in a second. But while I wait for that to come up, Dr. Wale Olabi is the Director of Pediatric Cardiology for Hospitals for Humanity. He's also the Chief Medical Director for Pediatric Cardiology Consultants of South Texas and San Antonio, Texas. He is a brilliant and dedicated pediatric cardiologist. He trained over in Texas Children's Hospital. I have a slide coming up. Perfect. Thank you. He possesses proficiency in cardiovascular outcomes research, and he's also a member of the Pediatric Cardiology Consultants of South Texas, again in San Antonio, Texas. He's a very esteemed cardiologist. His professional interests encompass inpatient pediatric cardiology and non-invasive imaging. He has a particular focus on the single ventricle programs and also transition of cardiology care from pediatrics to adulthood. I've had the privilege of working with him and having him as a mentor and as a friend. Please now welcome Dr. Wale Olabi, and he will be speaking on screening modalities for congenital heart defects.
I'm a pediatric cardiologist in San Antonio, Texas. Welcome to World Congenital Heart Day, which also happens to be Valentine's Day. We thank you for joining Hospitals for Humanities along with Access Bank to provide information on congenital heart disease. And today I'll be talking about nurturing young hearts, screening modalities for congenital heart defects. Thank you. So when looking at screening modalities for congenital heart disease, first we're going to talk about what is a congenital heart defect, how is congenital heart disease diagnosed, and then what are the modalities, electrocardiogram, echocardiogram, advanced imaging techniques such as CT angiogram, MRI, and also cardiac catheterization. Then we'll talk about the issues and potential solutions, respectively, for Nigeria. So what is congenital heart disease? Congenital heart disease is known as a series of structures and functional lesions of the major blood vessels in the heart itself. It particularly occurs during the time of fetal formation. So while the baby is in the mother and the baby is being formed, these congenital heart diseases occur at that time. Congenital heart disease is responsible for about 1/3 of congenital aberrations and is the most prevalent type of congenital disorders or disease. How is it diagnosed? It's primarily first diagnosed via clinical exam and also by testing modalities. Early detection of congenital heart disease is vital because the clinical manifestations and the worsening of symptoms may come suddenly, and then survival can be decreased if you have a late diagnosis or inaccurate diagnosis. We can use different modalities to diagnose congenital heart disease. Prenatally, when the mother is pregnant, you can diagnose congenital heart disease utilizing fetal ultrasound that's performed during the second trimester of pregnancy. And then after the baby is born, you can have a postpartum clinical evaluation in which you do a physical exam, You obtain the oxygen saturation, the breathing rate, vital signs, watching for how the baby's feeding, watching for increased respiratory rate or difficulty with breathing or feeding issues. Then we can do diagnostic modalities such as electrocardiogram, echocardiogram, and advanced imaging utilizing CT angiogram, MRI, and catheterization. In diagnosing congenital heart disease, we're going to start with talking about an electrocardiogram. An electrocardiogram is a simple test that is used to check your heart's rhythm and electrical activity. You use sensors that are attached to the skin, which detect the electrical signals that are coming through the person's heart. This occurs with each heartbeat, and over 10 seconds, the electrocardiogram is used to figure out what is the base electrical activity that's going on in a person's heart. Then you get a rhythm such as that on the screen on the right-hand side. So if you're going to get an electrocardiogram, what should you expect? Anywhere from 10 to 12 electrodes are attached to your chest. These electrodes then transmit the heart's electrical activity to an electrocardiogram machine, an ECG machine. We wait till the pattern is quite equal and quite smooth, and then we record that pattern either digitally or we actually make a printout of it and take measurements of the different intervals on the electrocardiogram to figure out that all the parts are normal, including the heart rate, the rhythm, and any types of heart block, anything else going on there. We can also determine in some forms if there's heart thickness or enlargement from an electrocardiogram. Next is the mainstay of congenital heart disease diagnosis, the echocardiogram. It utilizes ultrasound waves that bounce off different parts of the body, and these echoes, ultrasound waves, are picked up by the machine and turned into an image that is displayed on the monitor. This image then forms a 2D view, such as the image below, where you can see different parts of the heart. You can see the left atrium, you can see the thickness of the heart, you can see the mitral valve, you can see in different viewpoints. There's no radiation, so it can be performed as a fetus when the mother is pregnant to diagnose congenital heart disease in the fetal life. And then it can also be used to diagnose a congenital heart disease after a person is born. You can do multiple exams of these and not have any radiation, and you can use it to diagnose the function of the heart, how well the function is going on, especially in conditions like cardiomyopathies, in which the heart is sometimes weakened, or heart failure. It can diagnose regular congenital heart disease, holes in the heart, blockages in valves, and things like that. The patient can be awake. It requires limited preparation, just getting the patient calm. There's no necessary sedation or contrast to be performed, and you don't need to take up a lot of space to do it. It is the cheapest and least invasive method for diagnosing cardiac anatomy. Yes, electrocardiogram is cheaper than echocardiogram, but it's not really that great for cardiac anatomy. So the echocardiogram, the ultrasound of the heart, cheapest for diagnosing cardiac anatomy. So next, for congenital heart diagnosis and modalities, we'll talk about the CT angiogram. The CT angiogram is a non-invasive test, and it uses X-rays to take images of your heart and blood vessels for more information. The computer then combines the images to create a three-dimensional image of your heart. Back in the days, CT angiograms used to have a lot of radiation associated with them. They still have radiation, but recently, or more recently, multi-detector CT or MDCT work really fast, obtain images in seconds, and are very detailed. And you can collimate the images where your radiation exposure is very limited to about 3 to 5 X-rays versus like 100 X-rays in the past. So this produces better images with lower radiation exposure, and is the new forms of CT that are very fast and very detailed and can be very helpful in diagnosing congenital heart disease. This is an example of a CT angiogram where on this CT angiogram, you have the images of the raw images obtained. Over here, you have the person's head is up here, feet down here, front of the chest, and then the back of the chest over here. In the image here, you can see an arrow that's pointing to an obstruction in the aorta right over here. And then that also image is now used to create what's called a 3D volume reconstruction, where you can now look at the heart and almost like a 3D image, like you have something you can feel. You can move the image around and look at the structure or blockage or any kind of structure in the heart in multiple dimensions. So this is the advantage of CT angiogram, is to take those images and those abnormalities you're seeing and actually diagnose different things and see them in a more of a sort of like a real-life fashion. In addition, for other modalities for diagnosing congenital heart disease, you can utilize the cardiac MRI, which is a non-invasive test that uses magnetic field waves and radio frequency waves to create detailed pictures of the heart and the arteries. You can use MRI to look at tissue really well. You can look at valves well. You can look at, for instance, in this patient over here, the image A, you can diagnose mitral stenosis. You can also diagnose aortic valve stenosis. Over here, you have the aortic valve that is it's a bicuspid aortic valve with 2 leaflets, an obstruction over there. MRI is good at looking at cardiac anatomy, looking at how well our heart is functioning. It can diagnose if there is abnormality in the heart muscle itself, and can show those kind of abnormalities in cardiomyopathies and in the weakness of the heart. So it's a very useful tool to assess for congenital heart disease, to assess for hypertrophic cardiomyopathy, which is that condition in which people have really thickened hearts, and sometimes is a cause of sudden death when you see some athletes going down when they're playing sports. So MRI is a very useful tool, but can be a very expensive tool. There is no radiation with MRI. Next is in our diagnostic tool belt is a cardiac catheterization. Cardiac catheterization is an invasive procedure where you go in with a tiny catheter through a blood vessel to access the cardiac structures. So coming through the leg or through the wrist, sometimes you can go access the blood vessels and evaluate the cardiac structures. You can use the cardiac catheterization to diagnose and measure pressures and look detailed in the heart and see where a pressure problem is going on, and detailed in the heart to see where an actual obstruction is. Problem with catheterization is that it takes a lot of radiation, and it also takes a lot of infrastructure and skill sets and people to be able to do that. You can use it to diagnose a condition, and at the same time, you can also use it to fix a problem. Exhibit A over here, this patient has an obstruction in the aorta, also coarctation of the aorta. You go ahead and put a balloon in there. There's a wire here which might be hard to see, but then they balloon this area up and open up the area that was previously obstructed, and then that causes a relief of that obstruction over there. Same thing over here. That image shows the catheter going in here. There's a little dot here, and there's a little dot here. You open up the balloon, and you can dilate that area that's obstructed. So cardiac catheterization can both be a diagnostic modality to diagnose things and also interventional. So as we're wrapping up, the issues with diagnostic modalities are their availability and their cost, and the ability to be replicated in other places. The electrocardiogram and echocardiogram are very simple tests, and they can diagnose a lot of conditions, most conditions. You can have them anywhere, in smaller centers, bigger centers, and anyone who gets trained to use them can use them. CT angiogram and cardiac catheterization, they provide very detailed images, but they do use radiation, and there's contrast required. So patients that are pregnant will have to take lots of care to protect them the pregnancy, or not even doing that kind of test, and maybe doing a different modality. If a patient has kidney disease, you have to be really careful in calculating the amount of contrast you give, because you don't want to cause further kidney damage. All this advanced imaging, such as CT angiogram, cardiac MRI, and cardiac catheterization, can be very expensive per procedure done. And you can use that same amount to do lots of echocardiograms, or use the same echocardiogram to do multiple procedures on one person. So the cost is something we have to really take into mind. So solutions: is it essential to have multiple local areas for diagnosing heart conditions, congenital heart disease, particularly if we can have electrocardiogram in multiple different centers across different states? Then maybe we limit the advanced imaging structures, advanced imaging modalities, such as CT angiogram, cardiac MRI, and cardiac cath, to regional areas, and have those regional areas become the areas with high volume and high expertise. Then, if those areas are subsidized by the government organizations, we can have people go to those areas to go get those particular high advanced imaging procedures done there, modalities done there. The investments, particularly in the advanced imaging, cardiac catheterization, CT angiogram, and MRI, is significant because it takes a lot of infrastructure, millions of dollars to build a CT angiogram facility or MRI machine, or even a cardiac catheterization suite. Those cost millions of dollars to do. And so it's a long-term and progressive project that takes a lot of people to come together. The electrocardiogram and echocardiogram are cheaper, but still you have to maintain those. So this takes a combination of community awareness and support, and bringing the expertise of NGOs such as Hospitals for Humanity, and also working organizations like Access Bank. Plus, the government also has a role in this, and working in a public-private partnership can help to facilitate these solutions throughout our whole entire community. So I think it's possible. I think together we can do great things and have these modalities all throughout the country. Thank you, and happy World Congenital Heart Day, and happy Valentine's Day. Thank you.
Thank you very much, Dr. Wale Olabi. We're grateful for that presentation. Excuse me. We would at this time acknowledge very fondly our dear partners with this webinar and a lot of our intervention, surgical intervention. We have our partners in-house. They will have their time to speak. I just wanted to make a very big worthy of note that they are in the room. We have Access Corporation in the room. And we know that we all, are aware that in the last couple of days, they've been grieving the loss or the demise of their group CEO, Dr. Halbert Wigwe. This is a very, very, very painful and a big loss to all of us as a country, and even as an organization, Hospitals for Humanity. I just want us to, at this time, take a pause of about 1 minute just to give honor and reverence to a silence time in honor of Dr. Halbert Wigwe, his wife and son that just recently passed. Can we have just 1 minute silence before we continue? Thank you. Pray that God will cause their hearts, their beautiful hearts, to rest in perfect peace with Him in Jesus' name. Amen. Thank you for that. I will go straight on to a testimonial video. We have our impact stories. Like I said, we've been doing this for a long time. And so Hospitals for Humanities have stories of people that we have impacted by our interventions, and we would like to take one of that now. It's a story of a young, beautiful girl, Success Ene. And I would like you to sit back and relax and just watch and just hear the story from her and from her mom even as we share this story. Would also want as many people that want to take questions right now. If you have questions from what you've already heard from the speakers, please feel free to drop your questions in the Q&A portal on the webinar. We will pick the questions from there and we would answer them. Thank you. Please let's take success in now.
Success Mosene. Doctor said that she has hole in the heart. When I diagnosed, the doctor told me the first hospital that we went, they said she has hole in the chest because I've not been hit before. I was shocked. I said, and so the doctor said that there is nothing he can do. That the next level is to do her surgery. To understand that it's not in Nigeria, it's outside. When I heard this information, I was very happy. I believe God answered my prayer because I don't have anybody to help me. So when I see this program, I was very happy. I said, God has answered my prayer.
Thank you. Thank you for that very short clip of Success NS surgery. Thanks to our partners, of which Access Bank, here seated, is part of. Thank you so much for giving the gift of a heart to these children. We are super grateful for every support that we get, for all of our doctors that just come in selflessly to serve and to make this happen for all of these children. We love you. And today, a special day for love. We just want you to know that from our hearts, we truly love you, and we know the families love and appreciate your gift of the heart. Thank you. Dr. Money, over to you.
Thank you. Well said. Next, we're going to go to our next speaker. I believe the bio slide will come up in just a moment. But right now, we're going to have Dr. Asishana Osho. He's one of our cardiothoracic surgeons. He's also the Clinical Advisory Board co-chair for Hospitals for Humanity. He is a surgeon in the Corrigan-Mineham Heart Center at Massachusetts General Hospital. Also the assistant professor of surgery at Harvard Medical School. Specializes in adult cardiac surgery, heart failure, and thoracic transplantation. He studied in Oberlin College and also has a master's in public health from Yale. He did his medical schooling at Duke University School of Medicine. And he completed residencies in general and cardiothoracic surgery at Massachusetts General Hospital. That's Harvard Medical School. He conducts clinical, translational, and health services research to understand and improve cardiovascular health access. Across various populations. He has significant experience designing and implementing clinical trials in cardiothoracic surgery. He's going to be speaking on pre-surgical and surgical care for children with congenital heart defects. Please welcome Dr. Asishana Osho.
Okay, hello everybody. My name is Dr. Asishana Osho. I'm a cardiac surgeon at Massachusetts General Hospital, Harvard Medical School in Boston, Massachusetts. I'm also a member and one of the co-chairs of the Clinical Advisory Board for Hospitals for Humanity. I'm grateful for the opportunity to speak with you all today about the pre-surgical and surgical care of children who are being set up for congenital heart disease operations. So again, summarizes my introduction, and this is part of the Hospital for Humanities webinar series. The theme today being nurturing young hearts. So thank you everybody for attending. I have no disclosures currently that affect the presentation today. So in discussing the pre-surgical and surgical management for children with congenital heart disease, I wanted to highlight 6 different areas that we'll focus on. Initially, the history and exam of these patients going back to the time from when they were in utero during gestation, which I think has important implications. The next is the imaging, the things that help you make the diagnosis and prepare the patients for management down the line. I think it's critical next to think about the progression of patients and the things that we need to do to optimize them before they get to surgery. In many cases, these patients are waiting for surgeons to come or for the families to raise the money, and being able to optimize the patients during that period is important. And then we'll finish with the preoperative considerations, and then very briefly touch on some surgical pieces, because I know that some of my colleagues will be talking about the surgery for these patients later on in this session. So to jump right into the history and exam for these patients, there's so much that is critical here. The pregnancy and birth history of these patients is absolutely essential to give us a sense of what things were like in utero before they came out, and what pathology we can start to predict during this period. Knowing whether these patients made it to term or they were preterm, their size and things like that, and also gives you a sense of what types of pathology they might have had. The classic example being, prematurity being associated with patent ductus arteriosus and things like that. The physical exam at the time of birth is also very important. I think any recognition of birth defects and things like that, or abnormalities, also gives you a sense of what cardiac disease the patient might have. One of the classic syndromes being the Vactor L syndrome, with patients who have vertebral anomalies, anorectal disease, cardiac problems, tracheoesophageal pathology, and potentially limb disease, as well as kidney pathology. And these patients, again, if they showed up with any of these in advance, you could get a sense that some cardiac history was lying in the background. The patient's family history is also very important. Genetics matter, and some familial syndromes like DeGeorge syndrome, or patients who have a history of Downs in the family and things like that, might also give you a sense of what cardiac disease to expect. And then as the patients grow and come to you at later stages in the development, understanding what they've been able to do in terms of feeding and growth is critical. For many of these patients with congenital heart disease, they spend so much energy trying to breathe and deal with their heart failure that they can't eat and grow appropriately. So this again gives you a bit of a sign that their disease is progressing, or what types of pathology they have, period. And then finally, the cognitive development of the patient and how they look in the exam, in the office on exam, gives you a sense of their disease and the things that you need to keep in mind as a practitioner trying to take care of them. So next we talk about imaging. And imaging is really the cornerstone of making the diagnoses for patients with congenital heart disease. Chest X-ray is a study that should be obtained in all these patients and can give you a sense of what pathology they have right off the bat. This is a classic X-ray of a patient with tetralogy of Fallot. You see what we all have come to know as a boot-shaped heart, if you would. And things like this for other pathologies can be very important in sort of helping you understand what the patient needs. EKG gives you a sense as well of some diseases and some patterns of pathology, but within the whole spectrum of imaging, echocardiogram, which I've underlined here, is really the main thing that gives you a sense of the diagnosis. As a set of representative pictures, here's a VSD, which is demonstrated very nicely on echo in patients, and frequently it's helpful to also have Doppler. And this is demonstrated by looking at this same VSD, but with Doppler. And that gives you a sense of the compensation or the direction of flow in many of these patients. But an echocardiogram is really one of the most important things that we look out for in understanding patients with congenital heart disease and getting them to appropriate therapies. In certain disease states, especially those involving the vasculature, imaging modalities like magnetic resonance imaging, MRI or CT, are helpful in getting better definition of the size of arteries, the type of pathology the patients have, the specific configuration of arteries and things like that. So these are modalities that we use as well in these patients. Understanding acuity and progression of disease in our patients with congenital heart disease is critical. To spend a minute on presentations that can be fatal at the time of birth, this is really where acuity matters, and paying attention to the patient's hemodynamics and any evidence of cyanosis is quite important. The big things to keep in mind are the critical obstructive lesions, things like critical PS or critical aortic stenosis. And then patients who have some degree of ductal dependent disease with a duct that is trying to close early. And these patients can really run into trouble. The critical cyanotic diseases, the big one being total anomalous pulmonary venous return, demonstrated here in this picture with the veins emptying all the way into the right side, in which this patient has no way of generating pulmonary flow into the systemic circulation, which is an emergency. And then certain arrhythmias can be emergencies as well. The big one being a heart block for kids, and this needs to be managed very urgently. But also in understanding the progression of patients, how quickly the disease is going, it's important to get history from the patients about the progression of the heart failure symptoms. How has their breathing pattern changed? Where has the weight loss progressed? How have they failed to grow and thrive? And then also, how frequently are these spells of cyanosis happening in patients who have cyanotic heart disease? As I alluded to earlier, for many of these patients, surgery is not either the first necessary step or even possible right away. If we're thinking about a setting in Nigeria where patients frequently have to wait to get the procedures that they need. So it's important for providers to optimize these patients, these kids, well while they wait for surgery. Medical optimization has certain tenets for congenital heart disease that are absolutely critical. So in some of those emergencies that I talked about, having a patent ductless arteriosus is essential for the patient's survival. So having and keeping these patients on prostaglandin appropriately to keep the ductus open essentially saves their lives. So having that in the armamentarium, if you will, of drugs for patients is important. Diuretics are critical. Managing the patient's volume status with appropriate diuretic management helps patients survive. And then blood pressure management. And this is critical because by decreasing the afterload to the ventricle, you can actually allow the patient to do better. So ACE inhibitors are advocated as a critical drug in these patients. I have diuretics written there twice, but what I think I was trying to write was digoxin. And these types of drugs allow the ventricle to function better while also controlling the rate at which the ventricle works. This spares it from insults and help it work better. So, digoxin here as drug number 4, not diuretics like I've written. And then drugs for arrhythmia and blood thinners are two classes of drugs that are important in the maintenance of patients, some of whom have advanced pathology, and this prevents them from getting any strokes. The timing of surgery in congenital heart patients is likely out of the scope of this particular presentation, but showing a slide like this gives you the full spectrum of congenital heart disease that people can have, ranging from things like aortic valvular disease, stenosis, or the mitral or the pulmonic valve, to complex cyanotic heart disease like tetralogy of Fallot, disease that involve the great vessels, disease that involve directionality of the heart and the great vessels, which side comes off of what and how well everything is developed. You can imagine that the timing for surgery for many of these pathologies is different and depends on the specific presentation. Well, one sort of general tenet in the head that we keep is that for large vascular pathologies, even younger babies can be fixed, and these should be done somewhat quickly after birth. But for things that involve complex intracardiac repairs, complex valvular repairs helpful, so that these operations, which are already technically difficult, can be made more tolerable in the larger sized child. But again, talking about the full range of timing and disease that you need to think about in managing patients is probably worth its own 1 hour presentation by itself. Now, when the decision has been made to get the patients to surgery, they've been screened, they've been worked up, getting a sense of the things that you need to do preoperatively is important. We talked about getting the appropriate imaging and sort of reviewing that the day of the surgery is critical. But as you look to the surgery and get the patients closer, optimizing their nutritional and volume status is critical. When the patients get to the preoperative reduction area and leading into the OR, then you start to plan the monitoring that you need in the operation. And this includes things like urinary catheters for monitoring the urine output, arterial monitoring potentially with a pulmonary artery line, having plans to manage their rhythm with pads and leads. And then echocardiogram is important in many of these cases. You need to evaluate your repair, make sure there's no residual defect. And if you can get transesophageal echo, it's most convenient, but epicardial echocardiogram is also a good option. And then these patients need some degree of good venous access. And this is in many cases through a large bore central venous catheter placed in one of the jugular veins. Finally, to think about what things look like in the operating room, I believe that there's a conversation later on that focuses on surgery, but I do want to highlight the extensive teamwork that is required to take care of these patients. There is the anesthesia team that puts the patient to sleep and usually puts in all the monitoring lines, but they're greatly supported by the incredible nursing staff to take care of patients and get the operating room in order, keep the supplies coming, keep the thing running essentially. Pharmacists help us with the drugs for the operations, and then unique to cardiac surgery and in many cases congenital heart surgeries is a perfusion team, and these patients these specialists run the cardiopulmonary bypass machine, which is necessary because we often have to either stop the heart or completely empty it out of blood while we do the work that we need to do to fix the patient. And through a network of tubes and things like that, we're able to do that. And this group of specialists, perfusionists, are critical. And then all these teams are there to support the on-table team, if you will. And that is the team that's taking care of the patient, including surgeons, scrub techs, nurses that hand the instruments, and as discussed, the entire enterprise that you need to take care of patients who are undergoing congenital heart disease surgery. So I'll stop there and we'll move into the section for questions here, but just as a summary of the things we talked about, we discussed history and exam as well as imaging as you think about the diagnosis that patients with congenital disease might have. And we talked about the progression and optimization of care for these children. And then we discussed the preoperative and surgical considerations for children as well. Thank you all. Look forward to answering some questions.
Thank you very much, Dr. Shaw, for that presentation. We are grateful for your time, and we hope that we are learning. This is a webinar that we hope would impact as many people as possible. So we expect that we are also on YouTube and Facebook. We're streaming on our Facebook profile right now, so you can also share to as many people that you want to come in. We have taken questions already. We have some questions already in the Q&A tab. We would want more people to drop in their questions. Some of the questions would already be answered, and most of them will be taken to the end of the webinar, where we have slated to take the questions. If we ensure that one professional that is supposed to work with these children and understand what to do, or one parent that whose child is suffering from congenital heart defects or may have had symptoms and they do not know, benefits from this webinar, then our work would have been done. So we want as many people to just pay attention, ask all the questions that you're required to ask, and do not let this amazing panelists, amazing facilitators leave the room without you squeezing out all of the knowledge that you want from them. Right about now, we're going to be going into our next session with Nurse Joseph Christopher. Nurse Joseph Christopher is a dedicated and versatile healthcare professional with an extensive experience in critical care nursing and pre-hospital trauma and life support. Nurse Joseph will be talking to us today about post-surgical care for children living with congenital heart defects. Nurse Joseph is standing in for Miss Mina Shigok, who is also a practicing nurse and is one of our executive director in HFH. Nurse Joseph is standing in for her today, and Nurse Joseph is a member of the HFH team. He's the coordinator of all of the volunteers that work with HFH. Please let's have Nurse Joseph talk to us about post-surgical care for children living with CHD.
Good day. My name is Joseph Christopher. I'm a pediatric cardiac ICU manager with Hospital for Humanity. I'm a certified critical care nurse with Nursing and Midwifery Council of Nigeria. I want to welcome you all for today's webinar, being 14th of February, 2024. I also want to wish you a happy Valentine. So today I will be presenting on postoperative nursing care of a child with congenital heart defects. But before I go into my presentation, I will like to let everyone know that every child deserves the right to have access to medical care, irrespective of his background or social affiliation. So it is our collective responsibility to make sure that every child with congenital heart defects have access to free surgical intervention, if possible. So in that regard, I will like to share my screen as I present my lectures. As I earlier said, my topic is on postoperative nursing care of a child with congenital heart defects. So children with heart disease may require care in the pediatric intensive care units. And this reason for those care are management of cardiac failure, management of rhythm disease, and also recovery following surgical intervention of congenital heart defects. So a working knowledge of the assessment and management of children with congenital heart disease is essential for the practice of pediatric intensive care nursing. So I would like to categorize my lectures into different stages, which is pre-operative care, intraoperative care, and post-operative care. So during the pre-operative period, it is the responsibility of the nurse or the caregiver to make sure that parents are well educated and oriented on what to expect during the surgery and also after the surgery. And this will help in bringing down the tension of the parents and also for proper and good management of that child after the surgery, so that there will be understanding between the caregivers and the parents. Then this is also the ideal time for the caregiver to educate the parent on what to expect during and after the surgery, when the child is finally transferred to pediatric intensive care units. So during the preoperative care, those are the periods where the child can be assessed and managed and also treated conservatively before the child undergoes a surgical intervention. So management can also involve medication, administration of oxygen, intubation, and even mechanical support with a mechanical ventilator in order to stabilize that child. So during intraoperative periods, it is also the responsibility of the caregiver to create an open communication between the caregivers and the parent of that child. So because it is a difficult moment for the parent and also the caregiver. So if there's an open communication between the parent and the caregiver, I believe the parent's tension will definitely go down and they will not be bothered that something is going wrong inside the OR. Then during the postoperative periods, what I mean by postoperative period is the periods after the surgery, where the child will be transferred down to the recovery room or to the ICU. So in the operative, in the intensive care units, I would like to break down the nursing responsibility into different categories. And I will try to make it as short as possible because if I'm to discuss this in details, it will take almost 3 hours or 4 hours, if not more. So during that period, the first part of the postoperative period is the receiving of the patient from the operating room. That is the first responsibility of the nurse. Because during the preoperative period, the nurse already have all the data of that patient, the weight, the sex, the age, all the information that the nurse need to know about that patient. He or she have already gotten that information. So before the patient even come into the ICU, it is the responsibility of the nurse to prepare the bed, prepare everything that is needed to take care of that child post-operatively, and also set the ventilator. Even if there's a possibility that the patient will not be ventilated, but it is mandatory that before the surgery is over, the nurse should set the ventilator using the weight of the baby. So the ventilator should be ready to use before the surgery got finished. Okay, before the surgery is over. So, as I said, receiving and taking over of the patient from the operating room. Then the second part of it is airway management. So the airway management comes with ventilatory support because most of the patients are not extubated in the OR, that is the operating room. So they come into the ICU being intubated. So because of that, endotracheal tube is a foreign body in the airway. So the patient will keep on responding to the presence of a foreign body in the airway. So there will be a lot of secretion along the endotracheal tube. So it is the responsibility of the nurse to make sure that that tube is kept patent. We have the suction machine that you can use to suction the secretion along the airway. You can also suction the secretion along the oropharyngeal space. Then immediately after that, if there is a need for that patient to be ventilated, then the patient will be connected to the mechanical ventilator immediately. That is where the nursing responsibility become more and more and more difficult. This is because the responsibility of taking care of a child on mechanical ventilator is a very is actually tasking because that responsibility is divided into 3 stages: taking care of the child, taking care of the tubings, and also taking care of the ventilator. In the aspect of taking care of the child, you have to take care of the airway management, the skin care, the IV fluid, and all other things that you need to do for the child. Then in taking care of the tubings, you just have, the nurse's responsibility is to make sure that that tube is not kink. Because if the tube is kink, that child will get suffocated and will end up going to the other side. Then taking care of the ventilator, the nurse must have the knowledge of the ventilatory settings. This is because you can be left alone with a child in the ICU, and a ventilator will be alarming, maybe a low oxygen, high airway pressure, low airway pressure. If you don't have a prior knowledge of what the ventilatory settings and ventilatory alarms are all about, you will not know why that machine is alarming. A functional and a good working ventilator, if everything is okay, that ventilator should not alarm. If a ventilator alarm, that means there is something wrong with the patient or along the tubes or with the ventilator. So you will have to check. Then the next one is care of a child on the ventilator, which I rightly mentioned. After care of a child on the ventilatory support, we also have care and identification of different tubings that the child comes with. Why did I bring this? I brought this because when a child undergoes a surgical intervention of congenital heart defects, they comes out with a lot of tubings attached to them. Most of them are the central line, the arterial line. We have the IV fluids going through most of the venous access. We also have some of the cables that are from the monitor attached to the patient. So as you put the patient on the bed, the airway is being managed. Then you try as much as possible to separate all those tubings and make sure that you put them in the way they're supposed to be. Then for the arterial and venous and the CVP line, you zero them so that they will be fully functional. The next part is care of chest tube and underwater seal bottle. Every nurse must have a prior knowledge of chest tube management and underwater seal bottle management. Then we have strict fluid intake and output monitoring. It is very important that every ml of fluid that goes into a patient should be recorded. And every ml that comes out of a patient should also be recorded so that it will be balanced at the end of the shift and know if there's a deficit or there's an excess. And that will help in the management of that patient. In that aspect, the central venous pressure monitoring also helps in assessing the fluid volume balance of that child. Then we also have skin and wound care to prevent infection as part of the nurse's responsibility. We also have continual communication with parents, letting them know that the surgery is over and the child is now in ICU for close monitoring and continual care. After 24 hours of care and the patient becomes stable, most IV access should be removed. especially the arterial and the CVP line, when there is no much need for them. Then a peripheral line can be put in place. Then 48 hours after, when a child is stable, he can be transferred to the step down, where there is a less intensive care, but also a close monitoring will take place there. Then the last part of this lecture is the discharge teaching. When a child is okay to be discharged, the nurse's responsibility is to teach the parent on what to do at home and what the child should eat and what he should avoid. So it is very important for the parent to understand that a child should have a healthy diet. Then the medication that the child is going home with, he should take that medication exactly as prescribed. When a child, because some parents can decide to give a child a double dose, especially when they forgot to give that child a particular dose when they are supposed to give him. They will decide to double the dose and give him in order to cover the previous dose that the child missed. Is not proper. When a child misses a dose, if you don't know what to do, please kindly contact your caregiver. Then it is very important for the parent to bring the child for a follow-up care. Then they should also know who to call and when the need arises. And also who to call, when to call your healthcare provider is very, very important. Thank you. Thank you for listening. I have come to the end of these lectures.
Thank you, Nurse Joseph, for a wonderful presentation. We're able to learn a lot about all the different ways that the nursing staff and other staff are able to help to keep the children help to keep them in good condition after their surgeries. It's incredible to see their devotion to making sure that they're able to get out of the ICU safely and get home and to have great outcomes. We really rely on our nursing staff exceedingly. So that was a great presentation. Thank you. I'm seeing some questions coming in already. Some of them will be saved for the end, as has been said already. But please keep on putting your questions in the chat box. Some of the simple ones we will just answer there, but some of the ones that we think would make a better discussion, we'll talk about at the end. So please don't feel discouraged if you're just waiting. It just means that we want to talk about it some more. I'll go over to our next speaker. Or did you want to say something, Ms. Yoma?
No, not at all. Please go on to our next speaker.
So our next speaker, and that slide is going to come up in just a moment, but it is Dr. Teresa Pounds. So Dr. Teresa Pounds, she is a clinical pharmacy director for Hospitals for Humanity. She's also the program director for WellStar Atlanta Medical Center over in Atlanta, Georgia. Thank you. She is a distinguished professional contributing significantly to pharmacy and to healthcare leadership. She serves as the immediate past president of the Nigerian Pharmacists and Pharmaceutical Scientists Association, that's a NAPSA, and she's also the founder and president of the West African Society of Parenteral and Enteral Nutrition. This is a nonprofit organization that's dedicated to increasing awareness of malnutrition in Nigeria and beyond. So she is a malnutrition guru. She excels in metabolic support, medication therapy management, and also clinical pharmacy practice. And she also heads up a residency program development in Georgia, USA. She has a rich academic background. and she holds academic appointments at South University as a clinical assistant dean for clinical pharmacy education. And she's going to be talking specifically about malnutrition and nutritional support in congenital heart defects. So we welcome Dr. Teresa Pounds to speak next. Thank you.
Good day. Happy CHD and Valentine's Day. My name is Dr. Teresa Isiche Pounds, all the way from Atlanta, Georgia. I'm the current president and founder of WASPN, West Africa Society of Parenteral and Enteral Nutrition, and also a member of the Hospital for Humanity. It is my pleasure to speak to you today about some nutritional challenges in this patient population. What I will be discussing today, as I mentioned earlier, is nutritional challenges in children with congenital heart disease, with emphasis in the low and middle income countries, using Nigeria as a case study. I will start by sharing some background information, just a few statistics about CHD in these patients, nutrition support in these patients. Also give some key points about what are some of the prediction factors of malnutrition in our patients with CHD, leading us to the importance of using nutrition screening and assessment, and then also discuss the management of undernutrition and nutrition support strategies, and then end up by sharing my thoughts in terms of what the future directions when it comes to nutrition support in CHD patients should be. Starting with some background information, typically what we see in this patient population is poor growth. When you see a patient who is malnourished, you will see poor growth, underweight, and stunting is usually very prevalent in the children with CHD. Then one may say, okay, what are some of the contributory factors? Some of them are the severity of the heart disease itself, and some of the challenges, socioeconomic challenges that we see in low to middle income countries. Studies have shown that approximately 50% of the CHD children in the low-income countries exhibit some significant weight issues, most likely probably pre-surgery due to limited resources and delayed diagnosis. And I really want to emphasize this delayed diagnosis. And that's the reason why it's very, very important to try to identify the nutritional status of these patients very early. Infants and newborns are particularly vulnerable to this hypercatabolic state after they had surgery. But again, if you review the information in the literature, there's really no clear correlation that says that lower weight can lead to worse surgical outcomes. So I think the key points here are, in this patient population, malnourished patients, you will definitely see the poor growth, underweight, and stunting, and that early identification of the patient's nutritional status is very important. That leads us to how the definition of malnutrition. Malnutrition is described as an imbalance between nutrient needs and intake, leading to full clinical evaluation, which really makes it extremely important that in order to really see that patient's nutritional status, one needs to have the clinical information about the patient so that we'll be able to put everything together. Of course, the weight is also one of the things you have to look at. In low-income countries, the prevalence of abnormal preoperative anthropometric is high due to late presentation. What I'm trying to say there is, in this patient population, in these low-income countries, malnutrition is important. I mean, it's evident in this patient population. Again, factors that can predict malnutrition, as I mentioned earlier, is whether the patient has heart failure, older age at correction, and then also limited growth potential. Now, what this slide is showing is an approach to nutrition in the child with failure to grow or gain weight. And it's usually a good, this algorithm is showing some of the things I mentioned earlier, like some of the parameters that you can look at to assess the patient's nutritional status, and also leads you to some of the clinical information about the patient that will also let you know what is going on nutritionally. For example, you can see the starvation, some of the clinical situation with the patients like starvation, the malabsorption, nutrient loss. But what I would like to focus on this slide is once that patient is diagnosed that they are malnourished, then it kind of tells you also some of the key points that you will see. And that's where I really want to focus. When you see where it says malnutrition and the arrow pointing to some of the consequences of malnutrition in this patient population, like, for example, the loss of lean body mass, the muscle weakness, developmental or intellectual delay, infections, immune dysfunction, delayed wound healing, prolonged hospital stay. These are the consequences of malnutrition that you see in a patient who is malnourished and probably is going to be having like a surgical procedure. Delayed wound healing is pretty much common. That's where you see the patient had surgery, the wound is not healing. And then what this does, it really impacts the length of stay of that patient in the hospital. And then this adds to the economic situation whereby it's driving up the cost of the healthcare. So key point takeaway here is some of the consequences of malnutrition, some of the key ones, infections, like I mentioned, immune dysfunction. That is why nutrition screening becomes extremely important. Having an idea of some of the things we will see that will give us a clue or that this patient is malnourished. Once that's done, then the next thing, for every patient that is admitted, either in the hospital or even in the community setting, to do what we call the nutrition screening. So the nutrition screening is actually the process of identifying and referring those patients or populations who are at risk for nutrition-related problems and are appropriate for nutrition care services. So in our patient population with CHD, we already know that they fall into that category of being high risk of being malnourished. So doing the nutrition screening can quickly identify what their nutritional status is and can quickly help us to start the intervention of nutritional care management. Now, this is an example of the kind of screening tool for those who are in the audience, who are clinicians and want to use this information. So every institution should have some kind of screening tool. So this is a pediatric screening tool, and I will not go into details about what the components of this is, but what this is actually doing is looking at key information that will lead us to an objective information as to what the patient's nutritional status is. So it will lead the clinician, it will ask certain questions of the clinician, and then at the end, that clinician will have some objective number that will really show whether the patient is at nutrition risk or not. After that patient is screened and the patient falls into the high risk category, then the next thing is the nutrition assessment. the nutritional assessment is a systematic approach for collecting, classifying, and synthesizing important and relevant data to describe nutritional status related nutritional problems and their causes. So in a nutshell, what the nutritional assessment is, and it's typically done by the dietitian. Doesn't mean that any members of the nutrition support team cannot do it. And it actually gives the conclusion that, oh, this patient is malnourished. This is the amount of calories or protein that the patient needs. And then the clinician, a lot of times, which is a physician, then can now decide what type of nutritional regimen this patient needs to be on, whether this patient has a functioning gastrointestinal tract and they can use that tract. In most cases, is the enteral alimentation, or the patient does not have a functioning GI tract and they have to put that patient on parenteral nutrition. This brings me to nutrition support strategies. So after we have done the screening and have done the nutritional assessment and have concluded that this patient is malnourished, and this patient and what's going on clinically with the patient in terms of the gastrointestinal tract, then that's when we start talking about the nutrition strategies. I want to stress again that early diagnosis and interventions is the key to improving what's going on with that child or the patient nutritionally. I also want to stress that a comprehensive preoperative assessment is essential, and that's what I discussed earlier in terms of the nutrition screening, then the assessment. Then that giving adequate calories helps in terms of the growth in this patient population. That enteral nutrition is preferred, whether it's in the neonates, pediatric, or the adult, and that leading to that enteral nutrition is the preferred route for many reasons. One of them being that it's physiological and it has a lot of favorable effect when it comes to the intestinal mucosa and has fewer complications compared with parenteral nutrition. Typically for post-operative nutrition, if that gastrointestinal tract is working in that patient, then it's recommended that we start initiating enteral nutrition or enteral feeds as soon as possible after surgery. Parenteral nutrition, like I mentioned, is reserved for the situations whereby the enteral feeding is impossible or sufficient. Now, this algorithm, and I apologize, probably is a little bit busy, but the key point it shares here is the initiation and advancement of nutritional intervention. It's stating that nutrition management in the early postoperative period, is key, and that knowing which way to go is also very important. And then it's also giving some guidance in terms of what to do. Now, what it's saying is that it tells you about the recommended duration of withholding feeds after surgery. And the key point that this slide is trying to show again is what I kind of was discussing earlier. If the gastrointestinal tract is working, obviously we want to use the enteral route. Now, if the gastrointestinal tract is not working, then we want to go with the parenteral route. It's also giving some guidance for the nurses if the patient is on enteral feed, how they need to monitor the tolerance of enteral nutrition, making sure you're checking the gastric residual so that the patient is not aspirating, and then how fast one can kind of advance the tube feeding. Parenteral nutrition, on the other hand, is indicated for those patients that do not have a functioning GI tract. Now, we have some things that are challenges for us in the low-income countries when it comes to parenteral nutrition. And one is the cost. the products that are used for parenteral nutrition are expensive. Availability of these products is a challenge. Not many people can afford it. And then the training of the personnel that also administer this parenteral nutrition is also another consideration. So when you look at the cost, look at lack of dedicated personnel that can ensure safe prescription and delivery of parenteral nutrition, and also some of the complications pertaining to parenteral nutrition, then that really makes parenteral nutrition a challenge in a lot of these countries. And that's one of the reasons why WASPEN was founded by me to kind of see how we can address some of these challenges that we have. The training of the personnel, really ensuring that all the key disciplines are involved, and also trying to address, the availability and affordability of these products, because parenteral nutrition is definitely needed in those patients that are malnourished and do not have functioning GI tract. So I can say that it's definitely warranted, especially in our critically ill patients after congenital heart surgery, in situations in which the enteral feeding, like I just mentioned, is contraindicated or is insufficient to promote adequate growth. Post-surgery. Following post-surgery and looking at surgical recovery, one also has to look at, okay, so this child has gone through surgery. We've identified the nutritional status. We've started, we gave that patient the appropriate nutritional regimen, and this patient is now stable, and this patient is going to be discharged home. What happens in terms of nutrition after that? Again, is important. Not only nutrition important in terms of while they're admitted, to make sure that they're screened and you've identified the type of their nutritional status, and you've started them on the appropriate nutritional regimen. It's also very important that once they're stable and they've been discharged, that we continue to focus on their nutrition post-discharge. So that's what this slide is saying, that following the pediatric discharge, that we should pay close attention to the nutrition, and that there should be ongoing nutrition screening and nutrition counseling, and that we should use the multidisciplinary team approach, meaning the physicians, the community pharmacists, dietitians, and nurses, and also the patient's parents could also be very involved to be educated that in terms of what they need to continue to look at for the nutrition in this patient. So looking at future directions in terms of nutrition support, I think we need to do more research. That's one of the challenges as a clinician in this field that I'm saying. We need to do more research, and the organizations like Hospital for Humanity I'm really glad that we are focusing on nutrition in this patient population. I'm glad that we have a multidisciplinary team. We have members of this group, physicians, pharmacists, people who are even seasoned in nutrition. And I think one thing we can bring to the table is to identify those areas of research in nutrition and try to see how we can help, I mentioned about advocating for dedicated multidisciplinary nutrition support team to improve postoperative outcomes. So institutions should have nutrition support teams. And that's one of the things too that WASPEN is trying to do, to kind of work with various institutions in Nigeria, support them in terms of training to see how nutrition support teams definitely can be, formed. I think those are the key points that I want to kind of bring out during this presentation. I want to stress the fact that nutrition, malnutrition in this patient population is real. I want to stress that we have to identify the patient's nutritional status very early, and that's why nutrition screening is important. And then, of course, the nutrition assessment. And the key points I also made is malnourished pediatric patient with CHD with a non-functioning GI tract, we definitely want to use parenteral nutrition, and that we have to address some of the challenges we have with parenteral nutrition in terms of the product availability, cost, and also the training of the dedicated personnel. And also mention the fact that organizations such as Hospital for Humanity that are very interested in this patient population can join hands with other organizations to try to see if we can get more research done in nutrition so that we can be able to have more information, more data to be able to help with this patient population. So with that, I will stop, and I'll be glad to address any questions. Thank you.
Thank you so much, Dr. Teresa Pounds. Thank you for this very engaging lecture. We're grateful for your time. You know, I've been thinking, Dr. Money is here, but, you know, I've just been thinking sometimes that as doctors, you know, this training is so packed full. And I know that doctors are super busy, you know. This is me, you know, speaking to all of our specialists in the house. And I know most of them already are working with Hospitals for Humanities. We need to make sure this training or this webinar has a medical point, because I know that doctors are attracted to medical point systems. So I think that maybe when we give them some medical points with this, you will find a lot of them showing up in the room, because this, you know, I'm glad that it's going to be on our YouTube channel, and then we're going to begin to share to all of our, you know, to the database of all of the medical people that we work with. However, this is something that everyone that is a health professional should be listening to, and should be, you know, I'm already a healthcare professional by association, you know, not by practice in terms of technicalities, but I'm saying that just sitting here, I'm learning so much. And I know that it's something that every single person, whether is aspiring to be a medical professional or is already a medical professional working in this field, whether it be nutrition or it be nursing, this is so rich. This is so rich. Dr. Money, what do you have to say to this? What do we do to incentivize medical people to come in the room and sit in the room, right? Tell me.
No, I couldn't say any better myself, you know, the way you just said it. And I think that's one of the plans that we have down the line, to try and see if we can find a way to have people earning CMEs when they come for this, because it's definitely they definitely deserve it, you know, to come and sit and listen. It's also adding to their wealth of knowledge and best practices. So it's definitely something that we'll be trying to figure out how to make sure that we can deliver that, so that coming for this also has that added advantage as well.
Yes. I think doctors like incentives like that, and we would make it happen in the next webinar, God willing. Okay, so right about now, we want to take another impact story. We want you to sit back and watch the impact story of Fagbemi. Fagbemi is one of those children that that was part of our surgical intervention last year, May 2023. Please watch Fagbemi story.
is Augusta Fabrini, and here is my son, Sean. I had him 6 years ago, and when a woman has a baby, one of the most traumatic news you can get is to be told that the newborn has hole in the heart. I was not so happy. I was not happy about it. So since then, from that moment, I've been looking for ways to find solutions to the problem. I thank God I was able to get in touch with Hospitals for Humanity, and they are here to provide a free open heart surgery for my son. Thank you, Hospital for Humanity. Okay, my son Sean has gotten his heart surgery done, and we are going home today. I'm so excited, I'm so happy, I'm grateful, and I want to use this opportunity to say thank you, a big thank you to Hospital for Humanity. Thank you for the good work you're doing. Thank you. God bless.
Oh, I had the privilege of being at the medical mission where Sean was repaired, and it's such a beautiful story just to see him go from how he was before the surgery, and afterwards smiling, and his mom being so happy. It's really moving. It's such a blessing. So, did you have more to say, Sioma?
No, just sitting back and watching, it's pretty emotional. Because every child is deserving of a good heart. We can't say why it happened, but we can be the bridge to make and correct what has happened, and every one of us have a part to play. That's just what it is. Yeah. Thank you. Hospitals for Humanity. Thank you. All of our doctors. God bless you.
So now we'll have the privilege of hearing from Sean's surgeon. Believe it or not, is our next speaker. So I believe the bio will soon be shown on my screen. But it's a privilege for me to introduce Dr. Zina Makija. She's a congenital cardiothoracic and vascular surgeon, and she's also did her fellowship in cardiothoracic surgery in Mayo Clinic in Rochester, Minnesota. She's a highly skilled pediatric cardiac surgeon. She graduated from the Lady Harding Medical College, and she did extensive training in cardiothoracic surgery, both in the UK and in the USA. She's had over 16 years of experience, and she specializes in complex congenital heart repairs. She's achieved mortality rates of less than 5%, which is remarkable. And she's also received multiple prestigious awards and been involved in different publications. She currently leads the congenital cardiothoracic vascular surgery program at CARE Hospital, India. Thank you. It's a little bit small. She's renowned for her contributions to pediatric cardiac care, and she's a very respected figure in the medical community. She did some amazing surgical repairs on some of our patients in our last program in May of last year, and it's just been such a wonderful experience having her ally with us and making such a difference in the lives of these children and these families. So please welcome, without further ado, Dr. Zina Makija, even as she presents to us. She's going to be speaking to us about she's going to be speaking to us about the surgical interventions for congenital heart defects. I'm talking about where we are now, experiences in medical missions, and also a vision for the future in Nigeria. So please listen. Thank
you. Good afternoon, everyone, and thank you for your kind words. It's an honor to be given an opportunity to talk about congenital heart disease, a brief synopsis in Nigeria, along with this great initiative by Hospitals for Humanity. I'll begin my presentation by giving you a little overview of what is a cardiac link nurse, since what we are going to talk about is a little bit about the most common congenital heart diseases, then how the NGOs have contributed to the current status of those cardiac surgeries being performed in Nigeria, where Hospitals for Humanity comes in, and how we can achieve the dream of a self-sustainable congenital cardiac surgery program in Nigeria. So basically, the first important thing is to pick up the patients right. And this term I have picked up from the UK model of congenital cardiac surgery, that is a cardiac link nurse. Basically, they are qualified nurses who work in clinical areas within the network, which we think we have yet to develop in Nigeria. So who take responsibility for participating in the care of a patient, whether it's a child or an adult with congenital heart disease. They will then develop relationships with staff in the specialist centers with an aim to improve communication channels and facilitate education of the staff within their area of work. Now, they may not be specialized in congenital cardiac surgery, but they have a keen interest in patients with cardiac conditions. Why I mention this is because we are still looking to train the nurses in congenital cardiac surgery in Nigeria. So, but we have to start from somewhere, and this might be a good link to start from. Now, basically, currently we estimate that there are about 8 of every 1,000 babies born alive have congenital heart diseases. And about a third of them may have a mild heart condition and never require any treatment. However, from the studies, from what I picked up from the net is that the prevalence in Nigeria is between 5 to 8, but it may be higher, since some of the studies go as far back as 1967, and the last study, I think, was from 2021. Now, just a simple overview of how the heart is formed during the process of organogenesis when the baby is still an embryo and starting to form. It starts at 4 weeks, and that is how it looks when it reaches an adult as we go from left to right. I will not go more into the technical details. This is just to give an overview of how the defects may be forming in the heart if any of these things does not form properly. So if the septum does not form properly, the child may have an ASD or VSD. If one of the tubes does not form properly, the child may have pulmonary stenosis or coarctation of aorta. And if there is a combination of defects, then we go on to develop more complex cardiac abnormalities. Now, again, comparing a little bit the Nigerian statistics with the statistics from UK, because this is the most viable comparison I could find. When they say that now the outlook is, this is just to show you that the outlook is not that dismal in Nigeria or in African countries as such as we may make out to be. A baby is born in UK with CHD roughly every 2 hours, and up to 1 in 25, every 125 babies has some sort of heart defects. Now, 85% of the babies, they now survive into adulthood. And that is what our goal also should be here in Nigeria. And survival rate for some of the procedures, we have a 100% survival rate for some of the simplest cardiac surgery procedures. And the most important thing here to note that across UK, nearly 50% of CHDs are spotted during pregnancy. Now, that is what we should also aim at, to pick up the defects while the child is still in utero or before its birth, so that we can have a good planning as to how we are going to deal with it once the child is brought into this world. Now, on the right side, there is a little table which shows the percentage of the defects. These have been picked up from the various studies, and the year of the various studies have also been mentioned. So from 12%, we have settled to a rate of, the last study I could find was from 2013, which was 16.7%, the rate of the heart defects. Then this is how, just going back to the previous slide, where it just shows, this is just for a little revision or a quiz, if we could have time to play, that what are the different organs, this is the heart, and what are the different parts of the heart, which we should all be able to spot, and how the defects are formed. These are the labels, which if superimposed, we would have been able to identify all the structures. Now this shows how the right side and the left side, the blood flow is segregated in a normal heart. Red shows pure oxygenated blood, left shows deoxygenated blood, which has to go to the lungs for purification. Now, this is the incidence of some of the most common congenital heart defects, starting from like ASD, VSD tetralogies, which comprise nearly 46%. Then the incidence of transposition is still quite less, and PDAs are still found in 10% of the live births. Now, if we could guess, as we discussed earlier, if there is a defect in the upper part of the septum, as in the lower left image we can see, it's an ASD, and how that affects, then a coarctation is shown on the upper right, and a VSD is shown in the lower right. Now, then this is a tetralogy slide, which shows basically tetralogy comprises of 4 defects: PS, thickened right ventricular wall, VSD, and then the 4th is the overwriting of the aorta over the the septal defect. I'm not going into these details because I think most of us who are attending this webinar are familiar with it. These are just to give you an overview. Then again, as you can see in this slide, there is a defect in the upper part of the septum. So there is a right to left, there is a left to right shunt, sorry. The blood you can see will go from a high pressure to a lower pressure. This is a coarctation, whereas we can see around the PD or beyond that, there is a narrowing of the coarctation where the number 1 mark is there that obstructs the flow. So basically what it means is the left-hand side of the heart has to work harder to pump blood away from the heart to the rest of the body, which makes the child, which makes the LV ejection fraction lesser, the thickening of the left ventricular wall, and obviously there is cyanosis also. Then this is a transposition explained very simply. If we focus on the figure, sometimes there might be an ASD, VSD. You can focus on the numbers 4 and 3 to see these defects. You can see in mark 1, aorta emerges from the right ventricle. Mark 2, pulmonary artery emerges from the left ventricle. Then we can see a PDA here, mark number 3. So basically there is again shunting. The good or pure blood from the aorta is going down from a higher pressure system to the pulmonary arteries, which are a low pressure system. Now, this image shows you a pulmonary stenosis. You can see number 3 is marked pulmonary artery. Now, the stenosis can be at various levels. It can be at the level of the valve. It can be below the valve caused by the muscles, or it can be above the valves, which are the 3 types: valvular, subvalvular, and supravalvular PS. Now, this is a VSD again. You can see marked near 1, blood flowing from the right to left. Now, to give it, since we mainly wanted to discuss the synopsis of these CHDs in Nigeria, so this is some information which I have gotten online. As we can see the incidence of patient's age along with the ASDs and the mortality, how it increases. So whereas the most red is the most mortality, whereas the most green is the biggest chance of survival. So the simpler defects, ASD, valvular, VSD, you can see it all goes in green. So patients can survive up to 61, 63, 63. For Fontan, now the mortality consecutively, or you can almost say cumulatively, increases up to 64 years of age. Now, another common thing that we cardiologists or surgeons use to classify the lesions and to decide how we are going to approach them and what is their seriousness level for the patient and for us is cyanotic or acyanotic lesions. Now, the most common cyanotic lesions mentioned on the left, 5Ts, TAPVC, TOF, tricuspid atresia, transposition, truncus arteriosus. Here also, while we are managing preoperatively, if we cannot take the child up for surgery, we should aim for establishing a saturation at least between 75 to 85%. On the acyanotic ones are simple left to right shunts like VSD, PTA, ASD, although these can also become cyanotic in later stages and if not operated or taken or addressed at proper time. Or we can have an outflow obstruction causing lesions which can be acyanotic like PS, AS, coarctation of aorta. So here if we repair the defect, the surgeon has to aim for achieving normal saturations or near normal saturations, which should be at least above 95%. Then some of the neonates have to be managed in the ICU preoperatively. So this is what is another category we address as prostin-dependent lesions, basically to cause vasodilatation of the smooth muscle in the ductus and to maintain patency. Most important would be HLH, critical aortic stenosis, coarctation, and interrupted aortic arch. So what prostin does is, by causing vasodilation for the lesions which are dependent on pulmonary blood flow, it will improve oxygen by increasing the blood flow to the pulmonary artery. And for lesions which are dependent on systemic blood flow, it will improve blood perfusion. And that is how prostin can give us a window of time where we can arrange other things and take the child up for surgery in a couple of days, maybe. Now, the nursing considerations are very important. So these are just a few guidelines as to how a nurse in the ICU, irrespective of their cardiac training, can look at the patient and assess them, starting with ABC, like the basics of CPR or ALT, ALTS, which we are taught. Assess the cardiac output, color, temperature, perfusion, capillary refill. For blood pressure, use the right arm because left arm may show different pressure if there is a coarctation. Monitor the heart rate, rhythm, ECG, put them on a monitor if you think the child is critical. Look at the nutrition. And obviously, it's very important to provide critical information and support to the parents at this time because they are going to be our cheerleaders when their child is going through such a difficult procedure. Then the oxygen saturations, obviously, we have to keep an eye on that also, pre and post-ductal. So monitor the right hand or either foot, again, keeping in mind the coarctation. Not the left hand as it's influenced by the duct. Then target saturations if the child, irrespective of whether it's a cyanotic or acyanotic lesion, 77 to 85%, then you have a window of time. And the most important thing is you avoid tissue hypoxia. But if there is hypoxia, do not hesitate to administer oxygen. Now, again, these are some of the data which actually pertains to Nigeria. I mean, I can't zoom in on the slide. But if you see, this shows how the various congenital heart malformations are distributed in various parts of Nigeria and in African countries around it. So the most green ones are the ones which have the highest concentration of these CHDs. So if you see Nigeria in the Niger region, I mean, at least Nigeria comes in like deep green. Maybe it's because it's more developed, more studies have been done, people are more active here, so there is more reporting. But whether there is a bias because people are more active here, I cannot say being an outsider. Now, the graph at the bottom, again, it pertains to specifically to Nigeria. So it shows the concentration of the CHDs, the point or the age groups at which they are picked up. So as we can see, we even still have a high concentration of PDAs being picked up in 11 to 16 years of age, something which should have been treated before a year or let's say before 2 years of age. Then the second most common, obviously, is the ASDs. They go undetected, children are doing well, so that's why maybe people don't bring them for a checkup also that frequently. But on the right side, this little graph, so it's for parents as well as nurses. Whether, these are the things we can look at, whether the child is eating less, whether the child is not waking up for feeds. Absent femoral pulse can obviously be picked up only by nurses or someone in the medical profession. Then if the child is blue, low saturations are there, that can be picked up by the parents also, and that can probably enhance the reporting of children with CHDs. Now, this again provides us an overview of CHD in Nigeria. Now, on the left is a graph which shows basically all the disorders, I mean, all the health problems one can possibly have. So if you see the green one, the dark green is cardiovascular diseases. So how much globally it is there and how much in Nigeria it is there. And on the, again, right side, there is a percentage, and it is like how much it was in 1990 as compared in 2019. So that is the comparison we are looking at. So CHD is a problem which should be actually addressed because it's at high SDI, the death in millions, as you can see, the green one is above 0.75. So this is a cardiovascular disease problem is something which needs to be taken seriously by the government as well as the medical fraternity. Now, as an outsider, I cannot comment much, but only thing I can say, something that I have observed in India also, is that we don't have any specific details available about an online network. And as like in India, there is a lack of funding from the government. So often when I visit, we do run into roadblocks because of funding for operating some patients, although I must say that I have noticed an improvement in the last few years that I have been visiting. Now, I have visited the National Hospital Abuja quite a lot, so that's why I picked up this thing, but also because it is a university or a tertiary level center. So if we want to improve the CHD network, I picked up this hub and spoke model to ensure that the right level of care is offered to the patients, but it is up to the people there to decide. Now, level 1, you can have, level 3, you can have outpatients. So this is the lowest level. Local hospitals, they just pick up, diagnose, they then refer them to university level hospitals, level 2, which can do some procedures. And obviously, a level 1 or specialist surgery and procedures, the ones which we call as super specialty hospitals, should have a dedicated cardiovascular surgery department where they should be able to address complex cardiac surgeries as well. This is how we make the programs there completely independent of any outside support. Now, so I decided that we should show a one slide where we can even pick up the distribution of hospitals across states in Nigeria. So as you can see, quite a lot of concentration in Niger, like more than 1,400 hospitals in Niger, like 1565, Kano is there, and and maybe that's how people can plan. If the most focus is there, are the most patients also there? Do we have dedicated cardiovascular centers here? And how much of planning should be going in to pick up the patients from there, or how we can transport the patients from there to cardiac surgery centers if the center is in some other state, like not in this state? As you can see, the Federal Capital Territory has 752 hospitals, but I think the area also that it occupies is small. So I think it's pretty dense or pretty well doing in terms of the number of hospitals, at least that it has. Then now that was all the hospitals. Now this slide shows you specifically the cardiac heart surgery network in Nigeria specifically. So if you see the middle of the slide, there are 3 pluses all over each other. So those 3 major centers are in FCT, Nigeria, which is, I think, again, it's doing well, let's say. So some standards we have to adhere to if we want to improve the level of the cardiac surgery in Nigeria. I mean, these are the few sections, and people can mull over it and think whether we tick all these check boxes? Is there a network approach to it? Do we have adequate staffing and skills? Are the facilities good? Are the interdependent departments functioning fine? Is there good training and education? Are we auditing ourselves? Are we doing any research about our own numbers? How is our communication with patients? How do we transition the patients if they have to be transferred from one department to another? And then obviously we micromanage ourselves at the level of pregnancy and contraception to avoid such babies being born. Can we diagnose them fetally? And obviously, if we are not able to take care of some defects, how is the level of palliative care and bereavement in our country? This is a patient care pathway. I have picked up it from someone, and maybe we can go through it later on to decide how we can improve the patient care pathway in the hospitals where we're actually doing cardiac surgery right now. Again, these are the departments which should actually be in and around a cardiac surgery hospital so that all the needs are taken care of and we don't scramble when we need to receive an input from one of these departments when we operate a patient for pediatric cardiac surgery. Again, these are some of the numbers that I came up with, but they may be different. So basically, there should be adult and pediatric providers covering level 1, level 2, and level 3 services. Then there are over 6,500 children and 8,000 adults with congenital heart problems going to at least one cardiac center, which we deducted from the data that I have shown you about. So what we need to do is organize at least 30 clinics per week all over in Nigeria, so that we have at least we are able to manage at least 10,000 patients in OPD in a year. There should be at least 100 pediatricians in Nigeria right now with expertise in cardiology if we have to address the load and stop sending patients to foreign countries. We need at least 40 adult cardiologists with a specialist congenital interest. Then obviously we need specialist and link nurses, but we should be capable of performing over 300 heart operations in Abuja alone. And again, some of the inputs, like we need a website, we need a centralized depository of patients, we need an online data exchange system so that one state can liaise with another within Nigeria, and we need pediatric clinical nurses designated for schools also, so that these children can be picked up. We need to provide for support for babies and children, support for young people, support for parents or carers, and support for adults. Now, this is a slide I have picked up, a newsletter which is circulated in UK as a part of their South Wales network, just to show you an example how we can also circulate a newsletter and do better. There is a cardiac information board that they put out, in the hospitals for, teaching outside the seminar room, and network information is also there on these boards. Again, like this is one of the examples, which again, to show you a part of the UK network, how we can also spread more information about the same in Nigeria. Now, obviously, NGOs have been contributing very much to operating the congenital heart defects or taking care of them in Nigeria. So this is just a pie chart showing you which of the hospitals have been contributing and how much of the defects or the load they have taken off in Nigeria. Obviously, new NGOs have been coming up. I must mention here Hospitals for Humanity, because I have noticed that there is a shift in their thinking as they want to make the program self-sustainable. And we need more of such inputs so that the programs are not dependent on foreign care after a certain point of time at least. Thank you very much for listening to me. Thank you.
Thank you so much, Dr. Zina. That was an amazing, it was so exhaustive, coming from a surgeon, lead surgeon in the last program. Thank you so much for speaking to the sustainability of the cardiac missions in Nigeria also, and how, every part of what we are doing is pouring and serving into that big pot of sustainability. Thank you so much for that session. All right. Yeah. So we're seeing Dr. Zina's face. Thank you. Thank you, Dr. Zina.
I'm actually blurred actually, but thank you very much for having me there. Thank you.
Yeah, the pleasure is ours. And I know you're still in the room. Dr. Moni is just grinning. I'm sure she wants to say something.
That was an excellent presentation. Thank you so much for taking time, Dr. Zina, and touching on everything so elegantly.
Thank you.
Thank you. Right about now, we'll be taking a team pretty important to us. We've said it before when we started, and we also had a 1-minute silence for the group CEO of Access Corporation, who are one of our reliable partners in Nigeria. We have someone from the Access Corporation. We will take Ms. Kelly Sesonda of the Access Corporation. She's the lead corporate communications team. She's the lead of the corporate communications team in the Access Bank Rwanda, and she would be bringing us goodwill messages from Access Corporation, our partners, on this webinar. Ms. Kelly Sesonda, are you ready?
Hello everyone.
Oh, so good.
Hello, can you hear me?
Yes, Ms. Kelly, we can hear you.
Hello again. Thank you, everyone. This was a wonderful session. As we are near the end of this profoundly enlightening webinar, I want to take a moment to express my deepest gratitude to every one of you for your unwavering dedication to this important cause presented by Access Holding in cooperation with Hospitals for Humanity. So the wealth of insight and knowledge shared throughout this session holds the power, not just to inform, but to truly transform lives. So the discussion we have had have fortified our understanding and congenital heart disease, laying a solid groundwork for early detection and enhanced care as well. The knowledge we have acquired is not mere data, it is a beacon of hope, igniting efforts for early intervention and paving the way for more effective treatment strategy. It catalyzes elevating the quality of care, leading to improved outcomes and a better quality of life for those grappling with this condition. At Access Holding, we are deeply rooted in these issues affecting our communities and are steadfast in our communities to improve lives. As we draw closer to the conclusion of this webinar, let us remember our mission. Let us take this knowledge and turn into action. Share what we have learned with our communities, colleagues, and loved ones as well. Advocate for routine screening and spearhead awareness campaigns. Supports organizations tirelessly dedicated to improve the lives of individuals with congenital heart disease. Let us all remember that we all have our diverse role to play, and our collective dedication to this cause is unstoppable, is an unstoppable force. Together, we have the power to make a profound and lasting impact on the lives of those affected by congenital heart disease. Let the information we have shared today serve as a catalyst for a brighter and healthier future for them. And as I conclude, I extend my sincere thanks once more for your active participation and unwavering commitment to this cause. Together, let's continue to shine a spotlight on congenital heart disease, ensuring that every heart, young or old, receives the care and attention it rightfully deserves. Thank you all. Thank you so much.
Thank you, Ms. Kelly, for that very warm appreciation of the work we do. And we also appreciate the Access Corporation team for your dedication and support to this cause. Thank you very much.
Thank you. Thank you so much.
Yes, definitely. Thank you so much for helping us do what we try to do. We couldn't do without all our sponsors and all the caring people who give and support us and partner with us in different ways. So it really makes a huge difference. So next, I'd like to announce that we are now going over to our Q&A session. So I'm sure everybody's excited to hear more. Some people have already taken the time to put their questions in the Q&A box, and we'll start with those. But if you have any questions that are coming up, I know we just got done with Dr. Zina's lecture, so if you have any questions that have come up, definitely put them in the box, or if it's something that you feel like you must speak, I can temporarily unmute you to speak your questions. So I would like as many panelists as can to please put on your video, even as you answer the questions. I have a question. My first question is for Dr. Olabi. Dr. Wale Olabi. The question is, considering the cost of diagnosis of congenital heart defects and also the expertise required, even when the machines or equipment are acquired, do you see the place of AI in helping in diagnosis, especially in remote areas in developing countries? So, Dr. Labi.
Good day, everybody. Again, my video is currently locked, so I can't. If you can help me unlock it from the other side.
Work on that.
Thank you. So the role of artificial intelligence is one that, it's the latest kid in the room. It's the new thing that people are talking about, and it's important. It's something that we have to consider and we have to look into in the near future. For the longest time in cardiac care and cardiology, there has been some role of AI in there, some automated things going, especially in the role of electrocardiogram, such that when you perform an electrocardiogram, the computer can pattern read what's there and come up with a diagnosis, right? And it still takes somebody like a physician to oversee it and say this is correct or this is wrong. So it's useful, something like electrocardiogram, in screening patients that are not right where the physician is. So sometimes, like over here in Texas, we do some screenings for teenagers and looking for causes of sudden death. And an EKG that's performed 2 hours away, the computer can give a sudden read that flags that there's a possibility something's going on here, and that can alert the non-clinical staff that, okay, this is someone that needs to be seen before even the cardiologist can overlook it. So AI has been in the field, but we need some more help. Echocardiogram is going to be a little more difficult because it's a little more technical in getting the images. But as that field advances and we get better or we get more automated ways of obtaining the images, then I think that will also help. Because once we have a standard way of obtaining it that's not manually, because right now echocardiogram requires a person going to go get images done. And if it's not done in the right way, you can get off images. But once we get a tool that way we can automate that process, then yes, we can probably use AI to read those images. There's some AI in CT and MRI, but that's not really useful in a outline setting. It's more in a tertiary center, like Dr. Zina was talking about, those second and third degree spokes in the wheel. But for outskirts, EKG is usable right now. And then next echo is probably the next step. But I think in the next 5 to 10 years, we can look forward to getting more AI involved. Thank you.
Thanks, Dr. Wale. That was a great answer. I wonder if you wanted to speak on, there's a question by Billy Kisu, Amuda Oladeji, that I was looking at. She was asking what Hospitals for Humanities is doing in regards to public awareness, education, and advocacy for pregnant women and mothers generally who do self-medications and take herbal concoctions during pregnancy, which that is a big concern, especially with the prices of everything skyrocketing right now and people are looking to turn into all kinds of different interesting remedies. I know I want to hear your answer, but definitely what we're doing today is part of it. So I think we definitely have to have some sessions that look more at maternal fetal health. And then the other thing is through because we partner with a lot of cardiologists on ground in Nigeria. So basically through the cardiologists, through doctors there, that's the most way that the education is being perpetrated. But this webinar is kind of a new thing, but hopefully we'll be able to do more sessions which focus more on those things as well and raise more awareness. But I'd like to hear what Dr. Alabi has to say about that as well.
So, well, like you said, Dr. Omenigo, this webinar and sessions like this is part of the way we facilitate education and speaking to as many people as we can, getting the word out there, putting it on YouTube so it lives on there and you can continue to share the information into perpetuity. We do need to continue to do more work. More work is needed in terms of education and teaching people. First, we're trying to, tackle some congenital heart disease, and then we have to tackle, like the question was, we have to tackle talking to people as to what they are taking during pregnancies, things that can lead to birth defects and things like that. So just more education from the ground up all the way to tertiary centers. As Hospital for Humanities, we are trying, what we can in our own way, and spreading that word from a congenital disease standpoint. But definitely our partners on ground, from Jude to National Hospital to all our different partners on the ground across the country, they'll suit everywhere. They are working on getting that word out that there's some particular medications you shouldn't take, and we'll continue to spread that word and get that word out and educate people as to what those medications can potentially cause. And if there's something going on, we try as much as possible to detect it during fetal life. That's probably the next advance in Nigeria that we need to have it more commonplace. There are a couple of places in Nigeria and I know now do fetal diagnosis, but we need to get that more commonplace to help diagnose things earlier. So we continue to push education and we continue to put the diagnosis throughout the country. Thank you.
Thank you.
Dr. Mani, could you check your mic? Seems like you're muted.
Thank you. Sorry. I said I had a question earlier that I believe that Dr. Oshaw, a CT surgeon, he had to leave, but he did drop an answer, which I've sent over. But I believe Dr. Toma might also have something to add to the question that was asked. And this question, sorry, just a moment, was, are there courses or sites where one can learn about each of these steps, even if you're not in cardiac surgery residency? So I think you're talking about the surgery aspect, and I believe either Dr. Toma or I don't know if Dr. Zina is still on, might be able to speak to that question. Thank you.
Yeah, I currently can't see the question. I had access to the questions before, but then lost access. So it depends on who's asking. If this person is a resident in training, then the right place to learn about this is medical training, medical school, residency training, and various courses that are offered by specialists in this area. Cardiac surgery is not only complex and very intense and intensive. It's about life. You're dealing with the heart. So even though there are courses where you can learn one or two things, hopefully it's just for information and not so you can go and try things. You know how they advertise, don't do this on your own at home, that kind of thing. Yes. So the purpose of this webinar is not to we're trying to simplify things just so people can understand, but it's not so that people can go and try things on their own. That's dangerous and highly irresponsible. So I would say that basically, the internet is full of all kinds of information that you can get, but as you collect this information, take it with care, and like we often say, make sure you pass this by a specialist, someone who knows what they're doing, so what you can apply and what you can't apply. This is not supposed to empower people to go and do things on their own. It's just to make it easier for people to understand and to know that, in some areas they need more knowledge and they should go to the right places to get knowledge. In Nigeria, I think that residency programs are opening up for cardiac surgery in places where open heart surgeries are being done. But the big problem is the volumes in many Nigerian programs are not enough for most people that are getting training. So many of these programs arrange for their residents to go out to places where they have the volumes, and then they can return and practice. And afterwards, there are like lots of opportunities for further training in different areas of cardiothoracic surgery that you can that you can access, again, by getting engaged with the right professional bodies. I don't know if that's adequate. If there are more specific questions, I'm ready to take them.
Well, thank you, Dr. Soma. I think that's helpful. I believe the other answers gave some places, because I know some people just want to see what does it look like or what are the steps and everything. Hopefully, like you said, not trying to do it on their own, because it takes several years to be fully trained in this. But if you were just interested in seeing the different steps or what they do, I believe I put in the chat some of the answers that Dr. Osho had said as well. I'm in concert with what Dr. Toma has said. So hopefully that answers that question adequately. Let me see if there are any other questions that are arising. So those are the questions that I have in the Q&A. I wonder if there are any other questions, or if anybody wanted to speak something live.
Okay, we need to start to round up because we've kept a lot of our participants waiting for so long and they've been so patient. I think we've had the best set of people in the room, just learning and taking in so much in today's webinar. Dr. Modi just asked if anyone has another question, so we can take that before we close out very quickly in the next 10 minutes.
I think there is a question. Oh, Dr. Labi, did you have a question or a statement to make?
Okay, no, it says no.
Okay, so hold on. I think there is one question. I think maybe I'll just need to unmute them to ask it to make things faster. So, Dr. Lolade, you're on. If you had a question you wanted to ask.
Oh, no, I didn't. I was just stating that the chat is disabled. You were saying you put things in the chat, but we can't see it.
Oh, so I meant the Q&A, the question and answer box. It's the question and answer where they're doing that. Sorry about that.
Great presentation. You guys are amazing.
Thank you so much, Dr. Lolade. Great having you. I think that's what we have for the questions.
Okay, very well. At this time, we would be rounding off in a bit, and we
I think one
more
says that he doesn't know if his question has been
okay.
But I can't see the question.
Okay, so we have two questions. So Kolawole Olalekan. Yeah, I can't see. Well, let me click it. You can't see it. I can't see it, but you can see that he's asking the question, right? I can hear you. Oh.
So, Okpayemi answered the question on the answered side. He, Dr. Kolawale, I think he's a resident. He asked whether there are opportunities to train, opportunities to volunteer, and so Okpayemi answered that there for sites for further engagement and volunteering. So I think he answered that. Yes. So, Mr. Kolawale, yes, we do have opportunities for you to volunteer with us. If you can click that link that Pharmacy Okpayemi sent to you or typed in there on the answered side of the questions and answered, that's a good place.
Okay, perfect.
Thank you,
Okay, so
sir.
there's a Victoria Graham that says she also had a question. Did anyone see that? Victoria Graham, from a student from University of Uyo.
I don't think she, I'm not sure if she put it in yet. Please type your question. She said she has one, but I don't know if she's put it. Type your question.
Okay.
I don't know. Let me look and make sure that she didn't have one that was answered already.
Okay.
Maybe she needs to be unmuted. She says she has a question. So maybe we can find her and unmute her.
Okay, let me do that.
Yeah, Dr. Moni, if I may, can I read her question? Because I can view the question from here.
Oh, okay, good.
Go ahead.
Go ahead, Chris.
Now, Chris, you're muted.
Okay, sorry about that. Can you hear me now?
Yes.
Yeah, the question says that, good afternoon, ma. It says, good afternoon, ma. My name is Victoria Inshak. So sorry, the network knocked me off. A final year medical student of the University of Uyo. I have a question. Though she didn't type the question, that is the end of what she typed in.
Yeah, we saw that. I think our question says also about opportunities for medical students. I think she's retyped it. And I think Dr. Wale has answered that. Interested in research. So she's asking for opportunities for medical students interested in research. She kind of typed that just now. Right.
Okay, if we can send out a link similar to the one we sent to Olalekan, that would be great.
Okay, great. So Pharmacist Okoyemi, please send Victoria a link. She can get information about opportunities for research. Thank you. Okay, so I want us to close out on this very quickly.
So we can send the same link to Chioma Okere. She's
Okay.
asking for opportunities to partner. She says that they're with the Joan Willow Pipe Foundation.
Okay.
Sorry, go ahead.
Sure, Chioma, we have opportunities for partnership and collaboration. So we'll be reaching out to you. Mr. Koyemi, please reach out to Chioma and give her the details to continue the conversations after the webinar. We'll be taking Dr. Segun Ajayi, our CEO's message, just as we round up very quickly this webinar for February 2024. Dr. Segun Ajayi, our CEO.
Yeah, good morning and good afternoon, everyone. I just wanted to come on and say a vote of thanks to everyone that participated in this webinar. We are greatly appreciative. And we also want to just say a note of condolences again to the Access Bank family for their great loss. Thank you, everyone, and we look forward to the next webinar. Have a wonderful day.
Thank you, Dr. Segun, for that very, very brief appreciation to all of our participants and most especially our sponsor, Access Bank Corporation, for staying through the webinar. We'll take our very last impact message and then we would be closing out from there. Our next other information to other webinars in future will be dropped on our social media platforms. You can follow us on Hospitals for Humanities. Check us on Facebook, on YouTube. Replay of this of this webinar would also be, is right now on Facebook, and it will also be on YouTube very quickly after this program. So please make yourself go back to keep listening and reach out to us. Please do not fail to connect with us. We love to connect with you in whatever form you want to reach out to us, whether it is that a child requires congenital heart surgery, or you are an organization that want to partner with us, or you want to find opportunities to serve, to volunteer, to research, or to be a part of our medical team. We are always willing to just work with you to be a part of this very huge family. Everyone's effort, everyone's work is valuable in HFH, and we look forward to sharing our impact with you. Dr. Moni, any one last word before we take the last impact story?
Not really much more to say, but thank you. It's been wonderful. Thanks for sharing your Heart Day with our Kids for Hearts. And we wish you all the best and going
Yeah,
forward.
I think we'll jointly say happy Valentine to them and have a wonderful day. Thank you for making the little heartbeats. Thank you. Can we take the last one?
My name is Shakina Frank. I'm 16 years old, and when I was 8 years old, I was diagnosed with a heart defect, and I underwent surgery and an open heart surgery to have my defect treated. During the surgery, prior to surgery, my life was a bit difficult. I wasn't really able to play with other kids because I would have shortness of breath. I would be sick often. I would not be feeling completely well. There's always something wrong, and no one ever knew what was wrong until I would also always be on medication, but like every single day. But no one knew what was wrong until I had my surgery. Well, until before I had my surgery, when they found out that it was due to a heart defect that I had. After my surgery, life was a bit hard because mainly I had these nights where it was so difficult to sleep. The surgery, the wounds, and the scars from the surgery were uncomfortable, to say the least. I struggled to keep my regular life and the life that I had after the surgery like apart, because as a kid, even after I had my surgery, I still couldn't play. I still couldn't do the things, and I couldn't do too many rough things, or I would be hurt or sick, or something would like happen. I needed to heal first, and it was really hard because I wanted everything to just snap and be fixed so easily. So for a year, I had like these nights where I couldn't sleep. I was uncomfortable. I had pains. Sometimes I would have to sleep on my back, which was very uncomfortable. I always sleep scrunched up. But after that year, life was a lot easier. I mean, I'm here now, so life was a lot easier. The wounds were healing. It wasn't hurting as much, but every few months I would get like a checkup with some of the doctors that treated me, just to make sure that that everything was okay with me, that everything was okay, and I wasn't having any side effects or any abnormal pains. So I would get like checkups. They would do echo scans just to make sure that I'm okay, and that everything they did to heal my wounds were everything they did to heal my heart was working. basically. Right now, I am in high school. I'm in the 11th grade. Next year it will be my last year. Next year I'll be graduating and going to college or university. And right now all I'm doing is preparing for my AP exams and my SATs, which are our state exams, to make sure I get into a good college and a good um a good school so I can broaden my career path. Right now, my career path,
is Pamela. I'm Shekina Frank's mom. I got to hear about Hospital for Humanity through the internet. I actually got a mail, I know, in a newspaper where I heard about Gift of Life. From I applied to Gift of Life. Then Gift of Life connected me with an NGO in Nigeria, in Jos. Can't remember the NGO right now. Then the NGO also linked me up with Hospitals for Humanity. It was just like God sent to me. And before I met with Hospitals for Humanity, I found out that my daughter Shekina had a congenital heart defect and needed to be operated upon like as soon as possible because she was not really growing well. She was falling sick frequently. At a point, there was a time we were admitted in the hospital and our immune system was just going down. Everything was not working nice for her. Her growth was not well. She was always looking sickly. And everybody kept asking me, is this girl okay? Until I found out that she was actually suffering from a heart defect. And when I found out, I was made to go for a series of echo. We're checking her and we're believing God for a miracle and also believing God for the funds to do the needful because we are told that the only way it can be corrected was through an open heart surgery. And you know what that means. It costs a lot. Then when Hospitals for Humanities came to my rescue, it was actually an answered prayer because I didn't have any hope of how to raise the fund. I didn't have any hope of how my daughter was going to survive the illness. But to the glory of God, Hospitals for Humanities came and they wiped away all our fears. They took away all the pains. They stepped into the shoes, the big shoes that no one can ever step into except God saved them. And they were able to rescue us. They were able to help Shekina. They were able to give us hope again. They were able to give my daughter a second chance to live again. And to the glory of God, I did not know Dr. Femi and Dr. Shegun, but the day he met us, he has always been the nicest person on earth that I've ever met so far, and he's still the nicest person. He was caring. He was as if he knew us from somewhere. But that was the first time we're meeting him. And he was like, Shekinah, you're going to be the first that will go in for the surgery. I thought it was a joke. But they actually did it. And even after the surgery, I was thinking these people are coming to tell me, oh, you have these bills to pay. But they did everything free of charge. And for me, that is the greatest miracle anybody can have. And they did not only do it, they did it, and they were also checking on us all the time. Even when I was made to travel out of the country, Dr. Sherry kept in touch, he kept, calling and checking on us to know how Shekina was faring. And this guy, everything happened in like within a twinkle of an eye that I cannot really explain. But all I can say is thank you, Hospitals for Humanity. You are indeed God sent to us. And after the surgery, fine, yes, the period for recovery is usually hectic. She had so much challenges because the heart has to heal. That's where the stitches were, and that was only the time she had little challenges. And Shekina is the only girl in the midst of boys. She wanted to do everything that boys were doing, but I was so scared I didn't allow her to do those things. But now, even though I still don't allow her to do many things, Shekina can do so many things that she couldn't do before. Shekina can run. Shekina can walk on the treadmill. Shekina wants to take part in every activities in school, which is something she wasn't doing before. Shekina makes friends with people. Shekina is no longer on any medication. Prior to the surgery, Shekina was always on medication on a daily basis, even after the surgery. I think for like after 6 months, we were still on medication until they wean us out of the medication. But now, all we do is go for echo every 2 years, and every report we've been getting has been positive. Her heart is functioning perfectly. There's nothing, no cause for alarm. And I know this can only be the work of God. And God used Hospitals for Humanities to help us to heal Shekina, to give perfect her heart and correct everything that were abnormal there. I'm here again to say thank you, Hospitals for Humanity, for giving Shekina a second chance and for being our family, because as far as I'm concerned, you're my family, and I will forever be grateful for meeting you guys. Thank you. Yeah, I want to advise parents to not to lose hope, to trust God, and to also trust Hospitals for Humanity. They are a selfless organization that is after the well-being of all our children. And I know for sure that if they can trust God and also have faith in Hospitals for Humanity and do what they are advised to do, the surgery will go successfully. They shouldn't be afraid. They should just trust God. It's not an easy task, but I just want to encourage every parent to not to lose hope. Trust God for a miracle, and they will also have the miracle that God gives to us. In Jesus' name.